All right, let's talk about something that trips up so many students in their vivas. Anteversion versus retroversion. You're definitely not alone if you've mixed these up. So in this explainer, we're going to clear up that confusion once and for all. And more than that, we'll see why getting this right is just so fundamental to your clinical skills.
So we're going to kick things off by really nailing down these four terms: anteversion, anteflexion, retroversion, and retroflexion. We'll get super clear on what each one means, but then we'll get to the real heart of it, the question you should always be asking. When does this anatomical stuff actually make a difference for our patients?
So here's our game plan. First up, we'll lock down the normal uterine position. Then we'll jump right into retroversion, what it is, what causes it, and crucially, when you actually need to worry about it. We'll also see how it connects to the bigger topic of pelvic prolapse, and then we'll wrap it all up with the absolute high-yield takeaways for your exams.
Okay, first things first. Let's set our baseline. Before we can talk about something being displaced, we have to know exactly where it's supposed to be in the first place, right? Take a look at this classic diagram. You can see the uterus nestled right between the bladder in the front and the rectum in the back. But what's really key here is its posture. See how it naturally leans forward? This characteristic forward tilt isn't random. It's defined by two very specific angles that we need to know. Okay, let's break this down because this is where the confusion often starts. Anteversion, think of that as the version or tilt of the whole uterus. The entire organ is tilted forward in relation to the vagina at about a 90-degree angle. Then you have anteflexion. Think flex like bending. This is the body of the uterus bending forward on the cervix at an angle of around 125 degrees. It's these two together, the tilt and the bend, that create that normal forward-leaning position. All right, so that's the normal setup. Now, what happens when that forward tilt is flipped? What if it tilts backward instead? Well, that's exactly what we're talking about when we say retroversion and retroflexion. And this image shows that contrast perfectly. On the left, you've got the normal anteverted position we just talked about. But look over to the right. See how the entire uterus is now tilted or bent backwards, pointing towards the rectum and the sacrum? That's the displacement we're focused on. So again, let's nail down this distinction. Retroversion is the entire uterus tilting backward. Retroflexion is the body of the uterus bending backward on the cervix. Now, in the real world, clinically, these two often go hand in hand. That's why you'll often just hear people use the umbrella term retrodisplacement to cover both. Okay, so we know what it is. The next logical questions are, well, how bad can it be, and what causes it to happen anyway? So clinically, we grade retroversion in 3 degrees, and it's all about how far back the fundus has gone. In the first degree, the fundus is just pointing back towards the sacral promontory. In the second degree, it's dipped further down and is lying in the sacral hollow. And in the third degree, which is the most severe, the fundus has actually dropped below the level of the internal os of the cervix.
When we look at the causes, they really fall into 2 big buckets. First, it can be developmental. Basically, the uterus just never moved into the forward position and kept its infantile backward tilt. The other bucket is acquired, meaning it happens later in life, and this can be due to a bunch of things, like childbirth, which can stretch the supporting ligaments, pelvic organ prolapse, the sheer weight of tumors like fibroids, or even pelvic adhesions from something like endometriosis that physically pull the uterus backward.
Okay, so we've got the anatomy, we've got the causes. But this brings us to the most important clinical question of all. So what? When does this anatomical variation actually become a problem for the patient? Well, the first thing to realize is just how common this is. We're talking about 15 to 20% of women. That's almost 1 in 5. So in most cases, this is really just a normal anatomical variation, not some kind of disease or abnormality. And listen, this next point is absolutely high yield for your exams, so make a mental note. If the retroverted uterus is mobile, meaning it's not stuck in place by adhesions, it is almost always completely asymptomatic. It doesn't cause back pain, it doesn't cause pelvic pain. On its own, it really doesn't cause any symptoms. All right, now let's talk diagnosis, because here's a critical point, and it's a super common mistake that gets made during a pelvic exam. To get an accurate sense of the uterine position, the bladder absolutely must be empty. And this image shows you exactly why. A full bladder sits right in front of the uterus, and when it's full, it can physically push a totally normal anteverted uterus backward. On your bimanual exam, it'll feel like it's retroverted, but it's not. It's just being pushed. This is such an easy way to get a misdiagnosis. So the rule is simple. Always, always have the patient empty their bladder first. Here are 2 more really high-yield facts that often come up. First,
A retroverted uterus does not affect fertility. It has no negative impact on a woman's ability to get pregnant. Second, what happens during pregnancy? Well, as the uterus gets bigger, it just naturally grows up and out of the pelvis, and in the process, it corrects itself. This usually happens by about 12 to 14 weeks.
Okay, so far we've established that retroversion on its own is usually no big deal. But now let's connect it to a situation where it is a big deal, and that's pelvic organ prolapse. So what is pelvic organ prolapse? You can think of it basically as a hernia of the pelvic floor. The supports get weak, and organs like the bladder, the uterus, or the rectum start to descend or bulge down into the vagina. As you can see here, we broadly classify these into vaginal prolapse and uterine prolapse. And here is the crucial link. This is where retroversion becomes really important. In the most common type, uterovaginal prolapse, the whole process often kicks off with a cystocele, which is the bladder prolapsing. This descending bladder pulls down on the cervix, and that traction is what causes the uterus to become retroverted. Now think about it. Once the uterus is tilted backward, it's perfectly aligned with the vagina. So any increase in intra-abdominal pressure, from coughing, from straining, is going to push directly down on the fundus, pushing it further and further down. So you see, retroversion becomes a really important early step that accelerates the whole process of prolapse. All right, let's pull all this together. Here are the absolute key high-yield points that you need to remember for your exams. Okay, let's run through them. 1. It's common, about 15 to 20% of normal women. 2. If it's mobile, it's almost always asymptomatic. 3. You must empty the bladder before a bimanual exam to diagnose it correctly. 4. It has zero adverse effect on fertility or early pregnancy. 5. It typically corrects itself by 12 to 14 weeks of pregnancy. And finally, 6. It's often a key early feature in the development of uterine prolapse. Got it? So if you remember just one thing, remember this. The normal uterus is anteverted and anteflexed, leaning forward. Retroversion is a backward tilt. It's usually harmless and asymptomatic, but it's absolutely critical to diagnose it correctly and to understand its role in prolapse. So, take this out of the textbook and into the clinic. The next time you're preparing to do a pelvic exam, how is this knowledge going to change your approach? How will you make sure your findings are more accurate and insightful? That's what this is all about.